specifically targeted to understanding views of patients who are already engaged in research and who have had experience engaging in research, and what their own views and experiences have been. So I had proposed a schedule that would allow me time to develop all of these ideas together. And, these aren't discrete, separate things. The PPWG priorities and the ladders of engagement research and patient views, these are all interconnected. And so I made sure that in the project plan, there were lots of touch points back with the working group to ensure that, we were all kind of rolling in the right direction, that some of my interpretations were being challenged or agreed to, or, that we kind of kept with what their priorities were, and that my impressions were kind of being challenged or validated. And it's at this point, too, that I want to say, hats off to the committee for selecting me in the first place, because it's not an obvious selection. And, Anne introduced me as, loosely, I guess, as an advocate for patient engagement, and that wouldn't necessarily fit with how I would describe. My advocacy is for clarity and for critique and for exploring the things that are happening in addition to the things we think are happening. And so, I'm not personally motivated to look to improving patient engagement as a project. My own personal project and how I interfaced with this project was to kind of explore how people feel about what they're experiencing, what people say about what they're experiencing, and what kind of sense and meaning we can make of all of that. So I felt really privileged to be able to engage with patients at that level. And it really expanded my own thinking and appreciation also of the level of commitment and passion that people have for this work. So we can move on to the next slide. So for this particular study, I'm not going to spend a lot of time talking about the actual spectrum here, but this was included as an example that Asu maybe not specifically wanted to reference, but it was an example of a spectrum that many projects use as references, this IAP2 public participation spectrum. And just to be clear too, IAP2 is the, what are they called? The International Association for Public Participation. So it's not necessarily specific to healthcare. This has been adapted many times, many ways. It's often the sort of first benchmark or touch point that people use to think about how to include patients in research. But it was not necessarily designed with healthcare specifically in mind. Now, one thing to call out about the spectrum, which is distinct from a ladder, which I'll tell you about in a moment, but one of the things about the spectrum that the engaged patients all noted was that with the use of the arrow and the gradients and the way it's structured, it has this impression that you're somehow getting better from left to right, or that there ought to be a progression from left to right if the project is authentic or meaningful or not tokenistic. And I'm not, with all the reading that I've done, that's not necessarily what the intended representation of this kind of, these categories and these activities and things. It wasn't necessarily what was meant. It was simply that as you go from left to right, the perceived impact on the project or on the final decision increases with these different types of engagement. So it was interesting to me to note that this is seen as a ladder, as though you need to start from the left and move to the right. And that's a perception that persists very strongly, which is also, I think, why it's referred to as a ladder. So let's just agree that it's maybe a bit of a misnomer to call it a ladder, but it's the word that's used nonetheless. Okay, so let's get on to the details of the study. Where am I here? Okay, so yeah, you can look at the screen here. The names that were part of the task was to complete this study in a fairly short amount of time. So what I had requested and what was agreed is that the committee themselves, or the working group, would endeavor to provide me with suggestions of names, and we would try to connect into engaged patients in a fairly direct way so that there wasn't a big call and then trying to decipher a randomized. This was not a quantitative study where we were looking to get specific ratios. We just wanted to talk to people. So to facilitate that, as you can see, 10 names were suggested, and for a variety of reasons, 8 people were interviewed. And I did this through phone interviews. So just to be clear also, I did not trail people around in their engagement activities. This was not an ethnographic project. Rather, I asked questions and they answered, and we had a conversation. And there was no trying to validate the things they were telling me. These were accounts and their experiences and impressions, views, that kind of thing. So I recorded the interviews, transcribed them, made some analytical notes after the fact. And the composition of the participants were 6 women, 2 men. You can see it on the slides here. And I would say that in my experience, now that I reflect back on the composition of the participants, I would say they were kind of medium to very experienced people. Maybe 1 or 2 had light experience in participating in research projects, but I would say this was a very insightful group with a lot of breadth and depth of experience amongst them to be able to comment on their experiences. So I'll just say before we move on sorry, Eddie, I sort of triggered you. So in the interviews, I asked, I kind of had a plan. So there were 3 broad sets of questions. The first broad set of questions was about just simply tell me about your experience in participating in research projects. And then the second set of questions was their views on patient engagement. Not necessarily, partly their views on their experiences, but also based on their experiences, what are your thoughts on the state of engagement, on how engagement is run, how do you feel about engagement? And then, to circle it back to the initial point of the project was what are their views on the spectrum? And I asked them to actually look at the spectrum and have them comment on it, and we talked a little bit about it. And to be perfectly honest, for me, it was the least interesting part of the conversations, and maybe the part of the conversation we may have all guessed about where that would go, but we'll see. Anyway, each of the conversations really took on a life of their own. Each had a different direction and tone, and it was really quite fascinating to hear all the varying perspectives. And again, because this was not a quantitative study, this wasn't a survey kind of conversation. What I was really looking for as I was listening and as I listened back were to surface certain themes, what kind of language they were using, how did they describe things and some of their perspectives. So, I don't know that, if anyone was sort of looking for some sort of conclusive truth that came out of this, you'll be disappointed. We didn't solve all the world's problems. Maybe we revealed some more problems or something. Anyway, so we can move on from here. Okay, so this slide summarizes very broadly what we probably would have guessed at the outset. And so I'll just nod to them as we're looking at them. So broadly speaking, what I discovered was there was a wide diversity of experiences among the engaged patients, a wide diversity of opinions on broad and specific topics amongst them. The things that they agreed on were that researchers should seek out involvement of patients. How that looks varied from patient to patient. And that also patients should be given access to meaningful involvement opportunities and should be well informed about them, should be invited in, and that it should be a much more broadly advertised kind of activity. And also too, in this summary slide, it was clear that there were, even amongst individually, in individual engaged patients, it was difficult for each of them to even nail down conclusive opinions about things. So there was still a lot of thought process around the need for compensation or how representativeness plays a part, or meaningfulness, the definition of it. So individuals were still working out in their own minds what these things meant to them. And so it's not like each person had a very distinct, conclusive view, but there was lots of room for dialogue and a keen interest for people to hear from others and to continue on with conversations to help form their own views. Okay, so we'll move on, and I'll take a sip of coffee. I'll just ask, there's people in the room here. Am I going too quickly, or no, how are we? I understand. Okay, that's great. And I'm going to trust you to keep an eye on time, too.
Yep, I am.
Okay. All right, so patient motives, preferences, and intentions. Before I carry on with this, one thing I wanted to say, too, related back to what I was listening for when I was talking to the patients. I realized early on, and this was a hard impulse to fight, but it was not necessarily my job as the researcher and listener to figure out how and why they're all similar. Because I think part of the issue in patient engagement is from the project view or from the researcher's view, patients are lumped together. Okay, patients. We need a patient. They're all just patients. Let's grab a few. And so what I was really keen to hear was, and think about, was how and why some of these patient views are different, how they can be differentiated, and to explore a little bit where some of this diversity comes from. So things like, why are questions of compensation and representativeness so hard to agree on? Why are these such active debates? Is it just a matter of individual personality? Sometimes people, put it down to just, well, that's your opinion, this is my opinion. Yeah. So, and I thought, it's too simple to stop there, right? And to some extent, that's certainly true. We're all, of course, different people, but how helpful is it to just say, well, we're all unique and let's leave it at that, right? So I decided to see if there were ways that people spoke about their engagement that had some commonality, and some very interesting kind of analytical tools and analytical ideas came out of looking at or wondering about motives, preferences, and intentions. So why are people involved, and does that help us explain some of these tensions that arise amongst engaged patients? So again, only 8 interviewed patients, so please keep that context in mind. So this is not conclusive, these are not definitive, these are not the only groupings that exist, but these were the groupings that I discovered in this group, or that I chose to pursue in this group. And I think one thing that I found in talking to the working group at a number of touch points was that, some people felt that these groupings may or may not have been the groupings that they might have come up with if they had interviewed the same people. So let's just, please keep this kind of qualitative nature in mind of this particular study. So of the 8, the groupings were more or less even. Some groups had 2 or 3, I think they all had 2 or 3, some had 4 members of each group. So the group A, as I'm going to call them, were primarily interested in assisting with research as volunteers. So these were people who, through some kind of personal connection maybe, or a direct invitation from a researcher or a clinician, had decided to become involved as a volunteer to come and help out with an existing research project. Group B was similar, although they also had brought specific research or professional skills to the table, and in their minds felt that they, not in their minds, but in reality, they'd had experience in research projects before, or felt that some of their project management skills would be specifically helpful to a project. And then in group C, these were people who did not think of themselves, they may be in fact volunteering to some extent, but volunteer was not their role. Their role was as in leadership or as a spokesperson for patient engagement, and they were interested in shaping the practice of patient engagement. So the people in group C as engaged patients were, group A and B had a lot of similarities, and group C was very distinct in terms of their motivations for being engaged and the ways in which they wanted to be engaged. So this, to me, was quite an unexpected discovery. Well, I shouldn't say discovery. I mean, this is what I read into it. It's not as though it pre-existed and I stumbled on it. So the fact that people are drawn to engaging in research for different reasons is something I'm not sure I've seen explored in other studies before, or that motives had been studied. And I think often, and this is me inserting personal opinion here, is that as I've encountered other patients and looked at other projects and things, as I said before, I think researchers and from the project perspective, there's a view that patients are involved because they just want to improve healthcare. They're looking to do good things, but it's so broad and non-specific. And in fact, I didn't even necessarily hear from individual people that they were doing this to somehow improve the greater good of healthcare, that there were personal motivations, personal interests, there were personal relationships, there's all kinds of things in addition going on to that. And it's a much more nuanced kind of conversation to have about motives. And so again, I think this is what helps give us cues into some of the tensions. So one thing I also wanted to note here is Group A and B spoke quite a lot in our conversations about their personal experiences and what brought them into volunteering. So their personal narratives and their journey into volunteering as engaged patients was a critical part of who they were in all of this and why they were there. So bringing that experience into the research project was very important to them, and to be acknowledged for that, to be seen as being vital and helpful and instrumental because of their experience was a key part of why they wanted to be engaged. So being recognized for that, being treated respectfully, that was all very important, particularly to Group A and B, who saw themselves as giving of, bringing their experience and volunteering. And just an added note to the people who felt that they had specific skills to bring. One of them referred to themselves as, I found this quite interesting, as Patients Plus. Yeah. So they thought of themselves as bringing a little bit extra and maybe being all the more helpful for having skills. So experience plus skills helped Group B maybe feel like they were particularly vital to a project. And they were also very supportive of the idea of training volunteers and getting the rest of the patient groups slightly more trained, I guess, in their thinking and with the vocabulary, and that there was a mild sense in Group B that it was important to bring people up to speed very quickly, and that training and certification would help with that. An interesting piece that around this differentiation of groups was that Group C spoke very little about their personal experiences, even though they had deep personal experience in healthcare and with being involved in research projects, and their personal journeys in healthcare were compelling and highly significant. They did not care much to talk about that whole backstory. Their interests were much more about developing frameworks, about contributing to the strategic vision of patient engagement, about encouraging more patient engagement. And they themselves saw themselves as advocates for patient engagement as a discipline and as professionalizing and shaping the practice, and were maybe less, in our conversations, were less focused on their personal journeys. So I know I've spent a lot of time on this slide, but it really forms the foundation for a lot of the rest to come. So as we can imagine, with these, now that I'd kind of compartmentalized them into three groups, I went back and looked over themes and tried to sort of understand where some of these different views were. They all had quite distinct and differing views on what you see on the screen. So first of all, of course, the value of the spectrum and the value of having a framework overlaid on top of these projects. They all had different, the three groupings had quite different ideas about what that meant. And, given our time constraints and a bunch of other things, go read the paper and you'll find out what some of these are. But I'm just going to go through this list very briefly, but I've highlighted three of them I'm going to talk about in more detail. So the value of the spectrum itself was kind of a contested idea between the three groups of patients. These next three are the ones I'm going to focus on in a minute, but they thought differently about how to express level of engagement or depth of engagement and what that meant to them. The three groups talked about meaningfulness differently, and they talked about partnership differently. And these are all interconnected, so we'll get to those in a moment. But you'll also find that if you read the paper, there are some interesting comments about representativeness and whether patients themselves feel they are representing other patients when they come to the table, and whether that is an appropriate sentiment or not. They had views on that. And then also compensation. They all had different views on compensation. And you may find that interesting if you read the paper. So let's talk a little bit about level of engagement. I'm going to dig up the actual paper, which I've highlighted here. So level of engagement, right. So group A talked about how engaged somebody is depends on how much time they spend. So that was their definition. Because they're I'll just say, I don't mean to offend anybody with this word, but their currency, the thing that they're giving is their time, because they're volunteering, they're showing up, they're getting care for their other kids, they're organizing things at home, they're coming with their physical self to the project with time and effort. So their definition of how engaged somebody is how much time they were spending, whether it was in meetings, whether they had to do background reading, taking notes, whether there were webinars or calls they had to participate in. So the more time you spend, the more engaged you are. So that was their definition of engagement. Group B was similar, and these were the ones who also had research skills. They felt that they were more engaged if their professional or research skills were being utilized, right? So it didn't necessarily translate one-to-one about how many hours they were spending, but whether their training and their intellectual skills were brought to bear specifically on this project in conjunction with their experience. So it was their definition of whether they were more engaged or not, or whether they were functioning more as researchers or not. And then group C, interestingly, when I looked back on things, really didn't comment personally at all on whether they had a sense of their own level of engagement. And one of the things I reflected on in the paper is that's possibly because, these are, it's a kind of career direction for them, so their level of engagement can kind of be assumed that they're spending quite a lot of time and energy into this, and it would be kind of a strange question to ask them, what is your level of engagement in patient engagement? However, when they did, one of them did comment or did speculate that patients, they weren't talking about themselves, but they were talking about other patients' involvement, that their level of engagement could be considered higher the more they're required to know. So if the project is very complex, if there are a lot of moving parts, if they have to hold a lot of things and in their minds and kind of work things through in complex ways, then that meant they were more engaged. So that to me felt like this very interesting difference. So meaningfulness was also another point of departure that people spoke about. So groups A and B, for them, meaningfulness was almost entirely personal. So did they feel valued and helpful? Did they feel they had relevant things to contribute to a project? Did they feel it was a good fit for them to be there? Did they feel like they had something particular or specific to bring to a project? And if so, they felt it was more meaningful as an engagement. And they felt it was less meaningful if they didn't have as much to say, or if they felt a little bit out of the loop, or if their experiences weren't relevant to what was happening. So, or if they couldn't relate to the project at hand. So those were all indications to them that it was less meaningful. And for these groups, there was a lot of attention called to interpersonal interactions and behaviors. So how did researchers or kind of healthcare professional partners. How did they respond to them? How were they included? Was there eye contact? Were there thank yous? Were there expressions of appreciation? Was there a sense of appreciation from the others involved? And if the answer is yes, and if those are all things that happened, then it signaled to them, or it triggered in them feelings of meaningfulness. So this is meaningful because people are seeing me and engaging with me and hearing me. So feeling included, feeling valued, feeling that they were making good contributions made the engagement more meaningful. And often the word tokenism came up, or the flip side of meaningfulness came up, if those behaviors were not there. So they felt that it was a tokenistic engagement if they were not getting that feedback, and if those behaviors were absent, then they had no signal that that they were feeling value, that there was value for them. Group C, which is the more professionalized engaged patient advocate, they were looking back on the transcripts. They didn't talk about meaningfulness really at all in terms of their own engagement. So they weren't really exploring whether they felt that their work was meaningful or not. And it was not a theme that I was asking about directly. I didn't ask people how, do you think this is meaningful or not? I was looking for ways that they were organically using those terms. And Group C, for some reasons, I'm sure, did not spontaneously talk about what was meaningful to them personally in terms of engagement. So then the last piece I just wanted to call attention to in terms of what I found interesting particularly was their discussion about the term partnership. And unsurprisingly to me, and maybe to some of you too, but it was for groups A and B, the term partnership was very intertwined with meaningfulness. It was in some ways interchangeable. So if they felt that an engagement was meaningful, it was more likely that they felt like partners. So if they had a sense of being valued, of being helpful, it felt like a meaningful engagement to them, and therefore they had no trouble with the word partners. We are partners in this because this is meaningful for all of us at the table. So their sense of partnership was kind of it was based on a sense or a feeling of connection, and it wasn't really about a definition of a structure or a contract. I'm not a partner if we don't have it papered in some sort of legal way. That was not at all on the table. So the idea of partnership as a particular framework or structure didn't come up between groups A and B. But for Group C, the idea of partnership was much more codified. It was about, is there equal pay? Is there equal authorship? Do we have equal respect? Do we have equal decision-making at the table? How are patients, in technical terms, being integrated into this project from the very beginning, not just as sort of sources of feedback or as volunteer helpers? That to them was not partnership. It was something different. And that was not, they were clear that was not to be devalued, but that if you're functioning as a volunteer to contribute, that's not the same thing as partnership. I will say, though, that in Group C, again, that maybe this is reflective of some of the ongoing internal dialogue people have with themselves, but it was okay to still use, for one of them in Group C, the term partnership to signal a spirit of collaboration. So even if the project pre-existed and patients are brought in a collaborative spirit, and it's not hierarchical, and the patient view or the patient perspective is valued and is instrumental in forming the rest of the project, then that could fairly be called a partnership, that you're in partnership with patients, and that's okay, and that it doesn't have to be a literal contract. So there was a bit of kind of internal thought process going on in the conversation. But overall, I would say for Group C, the idea of partnership was much more narrowly defined. And for groups A and B, the idea of partnership was more expansive and more personally defined as to whether they felt that they were in partnership or not.
Wait, could we have some discussion?
Yeah. Well, one last slide, and that is so. I just sort of went through some of the key pieces that then led to a much more robust analysis section of what does this mean actually, what sense or meaning can we make of all of this. I'm going to, I think in the interest of time, I'll just leave this up on the screen for people to digest, but I did underline 3 key ones that I found either surprising or especially different from what I maybe was expecting when I went into it. And also, I would humbly propose these might form a basis for further study. So the first being that investigating motives, preferences, and intentions of engaged patients reveals more than just looking at patients as a monolithic, single, they're the patients, they're the researchers, let's smash them together and see what happens. So being more nuanced and appreciating individuals coming to the table. So that was one. The second is that the fourth point there, engaged patients do not always feel that patients in leadership roles adequately represent their interests. So this came out strongly in the paper, and I did not go into it much here, but that people in Group C, what was noted by those in Group A and B, there was a disconnect. There was not, Groups A and B did not feel that they were being consulted about how the structure and strategy of patient engagement should happen, that they were having talks amongst themselves, and that there was another separate group of patients advocating for specific types of frameworks and structures and ways of engaging and definitions of partnership. And the engaged patients who function more as volunteers, who feel a deep sense of meaningfulness and partnership from their own viewpoint, they felt that they had not been part of this defining of what patient engagement is supposed to be, other than talking amongst themselves. So that was a really interesting point to note, that there was some, we can call them tensions or we can call them challenges. And then the last point, and this has come up in other forums, I think some of you may have read the Healthy Debate article about expertise and definitions of who's an expert, who can call themselves an expert. But this came out loud and clear too in our discussions, that people have different meanings about what is a partnership, what is an expert, what is expertise, what is, all of these things are contested, and we shouldn't assume everybody means the same thing.
Right.
So I will stop there and move on to questions.
Great. I'm just going to unmute, and then Anne, you should be able to talk. If you are not asking a question, please do mute yourself. Anne, you guide the discussion.
Yeah, I just wondered if Jennifer's paper spoke to you in ways that you have experienced or noticed when you're involved in research. That's for all of the people participating.
Any thoughts or comments?
Oh, it was to Sharon. Does Jennifer's paper speak to you and ways that you have experienced or noticed when you're participating in research?
You should be able to just and ask questions. So Sharon, we can jump in.
Oh, hi, Sharon. Can you hear me?
Yep.
Yes.
Oh, sorry. So I'm sorry. I had to step out for a couple of minutes, but I mean, I think the findings in terms of the analysis, I think they do speak quite clearly in terms of specifically the ones that engaged patients do not always feel that patients in leadership roles adequately represent their interests. So, I find that quite powerful, because we often think about, are we really representing everybody? And what about the individuals who are not accessible? They can't, make it out to meetings, or English is not their first language, or culturally speaking, they're not, comfortable speaking up. So, yes. So I don't know. Those are some of my thoughts that I have, and that's something that I hear commonly. And I always wonder, as a participant in research, as a patient partner, I'm always thinking of, like, what hat am I wearing? And am I really representing the general public?
Yeah, one of the comments that a couple of people reflected in groups A and B particularly was and it was more a speculation, or it was more a curiosity question, but it was, on what basis are patient and leadership roles insisting on certain things? So the insistences that I think are quite public are about compensation and responsibility. So with co-authorship and with co-production comes a co-responsibility, right? And a lot of engaged patients are not interested in a second career or are not wanting to necessarily participate at that level, or in fact, many were quite resistant to the idea of being paid, or even other patients. So these kinds of ideas, I think there was some concern and maybe confusion as to who is deciding and on what basis these are requirements for a patient engagement framework.
Karen, you have a question?
Sorry, it's taking me a while to unmute my mic. But the question that I have is, just going back to the IAP2 framework that you selected, and I wonder what made you think about that framework over some of the other patient engagement frameworks, especially in research. Like, I know, off the top of my head, I can't remember, but there is like that triangle one. It's not, I think it's by Mullins, but I'm not sure, where, the patients or partners could be participating as from the most passive level as a participant to a more active level as a co-investigator. So I'm just wondering what made you select the IAP2 model over other models?
It was partly to just be expedient. That model was what was attached to the request for proposals as a clear, it was used as an example, but given that there was, such a broad mandate, and it was clear that, all of the patients had come from different types of projects where different types of frameworks may or may not have been used. This was not about proposing a framework. So starting from one that is often seen as foundational to building all the other frameworks. And it was also the one that also, maybe I might speak to how they selected it as an example, but it was, here's Eddie.
I can. So the reason that the IAP2 framework was put in as in the request for proposals is that that's the framework that the strategy for patient-oriented research at a grander level, this big national piece of work strategy on patient-oriented research, was using as its basis for patient engagement levels. And so that was given as the example in that stage. But you're right, there's more than one type, and we definitely wouldn't advocate that there's one that is the perfect one.
There was a question from Stan in the chat box too.
Oh,
Sean?
Stan?
I think it's Sean.
Oh, Sean. Oh, sorry. Can you speak up?
Here we go.
Yeah, meaningful engagement. So it's a comment. I found similar feedback from participants in research regarding meaningful engagement is very important to keep people engaged. So I mean, the word meaningful is just so, I mean, I can't hear that word anymore without wondering, where are we going with the word, because, there's so many different interpretations of it. It's that the meaningfulness needs to be concretized somehow, so people may feel this deep connection with the project, but if they're not getting the feedback, they start to question whether it's actually meaningful. So there's like personal meaningful, and then it's an interesting question, but it's a good observation that, if you're looking at sustainability and you're looking at keeping people engaged throughout a project, that sense of feedback, giving that feedback and validation is really important, and it also needs to connect with the person's experience. So just lip service about how meaningful you are or how helpful you are doesn't move it. If it doesn't connect with the experience of the engaged patient, then it feels hollow. Right. So it's not just the behavior, but the behavior needs to be consistent with how the person fits into the project. Mm-hmm. So being seen for the value that they bring.
Sean, did you have anything else you wanted to add to that?
No. Sharon had a question and wondered where, excuse me, Jennifer was going next. I assume she meant in her research.
Oh, that's a fun question. Well, I'll give a little plug for the. Oh no, I can't actually. No. And well, let's see. I've got a couple of talks coming up, which will I guess be advertised soon. I'll keep you posted. How about I say that?
Sorry to put you on the spot.
But I said I would wait until, yeah.
And I think next steps in terms of this particular work around the relationship with ladders of engagement, the way that it's seen differently, is we're trying the support unit to get this information out to people who might be able to do something about it. So understanding that the IAP2 spectrum is a really nice example of something that works quite well for projects, but is clearly understood very differently by people who are partnering in research. And so trying to see if we can move that message around to see what sticks, whether there are other people that can take up this work, start doing new things. I mean, Jennifer's point about the fact that there's an opportunity to talk about motivations. These are all things that we can try and create conversations around, and this webinar is a good starting point to see how we can leverage these conversations further.
One thing I'll add to this is I didn't talk further about the views on the spectrum, but I'll broadly say that there were two key pieces that stood out for me around views, and one was that patients were pretty clear that they were clear that they were unclear about the value of having these kinds of spectrums. That they thought of it maybe as a starting point. It was a good orientation, but that they didn't necessarily feel that it reflected roles or how, because their level of engagement was based on their own degree of participation and how that was meaningful to them. Seeing this spectrum of left to right and, consult and power and, none of that really resonated as activities that they were somehow involved in. It was not the vocabulary that resonated with them. And the other thing that I found interesting was many of them I interpreted that what they were saying was that it was a good socializing tool. So it helped, as I said, orient, but it also gave patients a view into how researchers think about their involvement. Yeah. So it was like, I see, this is how you see me. Okay, I understand. So it was more like, I see this as your tool. Thank you for showing me. Now I get how you think about me. So I'm very much paraphrasing here, but it seemed like it was not, patients understood very intuitively and quite literally that this was not about them, that it was about the researcher and the project, the framework.
Great.
Yeah.
And
thank you.
We can push on to the next bit of the webinar.
Yes.
5
Thank
minutes.
you.
Oh, sorry, I tugged up all the time.
Thank you very much, Jennifer. That was really great, and I'm sure everybody really appreciated it. And there's lots of other questions that will be perking under the surface there.
Yes,
So,
and feel free to carry on Twitter if somebody wants to connect with me.
okay, that's great.
Thank you.
Eddie, I think you had something.
I was going to very quickly identify at the end of this that there are some capacity building opportunities. We talked, Jennifer mentioned the idea that people being given the chance to be up to speed and be partners in research. So I wanted to talk about a few of the opportunities that exist around training, online training or capacity building for patient partners. And I will share this list, so please don't feel you have to write it all down right now. I'll share this on Twitter as well, and with anybody who's interested, we'll put it up on the website. A number of online training opportunities, some in health course program. There's one around primary healthcare, so for people who are interested in partnering in primary healthcare, there's one. There is a more generalized one around partnering in research in general called the Partners in Research program. We have just started an online version of what we call our master plan, which is trying to create opportunities for people to be leaders in patient partnership. And that's looking at people leading from patient partners' point of view, but also from researchers, from policymakers, clinicians, working in the administration of the health system. How can they all be leaders in patient research? And then one that's not anything to do with us, but is really interesting, research and experience, specifically around training for people who want to be involved in depression-based research. I've been asked to mute everybody, so I'm going to quickly mute everybody. Hopefully that will work. Hopefully that will. Oh, nope. I'm going to try and do that individually. If you can mute yourself, if you've got a chance. And I've also been asked if these are free programs. These are all online. All these online programs are free to attend. I will quickly move to the next slide because I know that we're running out of time. There are other couple of opportunities. There's a webinar tomorrow, again free, run by the Canadian Cancer Survivors Network about rare cancers and the involvement of research in that, partners and patients involved in research in that. There is a webinar being run by one of our sister support units out in Newfoundland in May, which is going to be looking at how you get from research to policy. So that will be another interesting opportunity to engage in what does it mean to be a patient partner in patient-oriented research and moving to changing policies. There's an interesting conference coming up, which is around genomics and society in June in Quebec, and that actually is going to be funding 5 patient partners to at least 5, I hope, travel awards for people to go and attend that conference to be part of that process. And there's also another thing online, using online videos, looking at citizens who want to engage in finding and using research evidence. This is another thing that we've been funding about through McMaster Health Forum. So if you're interested in finding and using health research evidence to really engage with the health system yourself as a citizen, there's an opportunity to do that now. I will pass over to Anne to just quickly close the session.
Thank you, everybody, for participating and for all your questions that you had for Jennifer. That was great. The ongoing series of webinars that we hope to host, we plan to have them quarterly, and the next webinar is planned for June or July of 2019. And we, excuse me, we would like you to submit some topics that you would be interested in us discussing during that. And we want them to meet your needs and interests. So, you know, send in your ideas and we'll look at them and see who we can get to speak to you to cover those.
So I've launched a poll. So those who are still on the webinar, you can vote in the poll as well. Those options that we've, the patient partner working group pulled together.
Okay. And I think that's it for me. Thank you very much, Jennifer, for your time. And
I'm just putting up those topics again on the slides. So you can look at those and decide if there's any of those that interest you. And as Anne said, feel free to email us or provide feedback to us in other ways on potential topics for the next webinars. Thank you very much.
Thank you, everybody.
I wondered if we could amend Jennifer's